Okay, everybody, here we go with special senses. This is chapter 14. This encompasses both the eye and the ear, okay? We'll cover the eye first, and the eye is really cool. It's really complex. There's lots of structures in there that allow us to be able to see images as we do. It does act a lot like a camera. I'm not a photographer, so I can't really equate it exactly, but we have certain structures that are very similar to a camera. So we have a lens, and the lens of the eye adjusts objects to bring it to focus in on the retina, and the ability of the lens to do this is called accommodation, and you'll see that word listed in the book. Then we have an opening that allows a certain amount of light to enter, okay, and that area is the pupil. That's actually a kind of the area within the color part of our eye, which is called the iris, okay? And that pupil, the muscles can either relax and open up and dilate and let more light in, or it can constrict and allow less light in, okay? And it is the combination of these two things, how much the eye is open, plus the lens, plus other structures, that helps to bend light rays so that the images actually reach the retina, which is where the nerve cells are, or the nerve cell layer of the eye, where the cones and the rods are, okay? And then from there, certain cells are stimulated, which actually then transcends and causes an image to be transmitted to the brain, okay? And remember, the brain, the part of the brain that's responsible for vision is the occipital lobe, which is posteriorly. Okay, so we're going to go through a bit of the anatomy. All of this stuff is in the book. There are combining forms that are associated with each one, with a lot of these, I'm not going to say every one, but a lot of these anatomical parts that we're going to talk about will have a combining form attached to it. So it's important to make sure you go through and familiarize yourself with that. Okay, so the sclera, which the combining form for that is sclero, is the white part of the eye. Okay, it's a tough fibrous membrane. It surrounds the eye, except at the front, and we'll talk about what's in front of that area. But it gives the shape, maintains the shape of the eyeball, and basically serves as a protection for all of the structures that are within it. Okay. The iris is the colored portion of the eye, and that can vary from individual to individual. Okay, but that's actually a small sphincter-like muscle that can either dilate and let more light in through the pupil, or constrict and let less light in. Okay, the pupil itself is kind of in the center of the iris, and it's the opening, okay? And it's the actual hole that either gets bigger or smaller and allows either more or less light in, okay? The conjunctiva, we don't actually see the conjunctiva. It's a kind of a thin, transparent membrane. That's a mucous membrane that we don't actually really see. It lies in front of the actual membrane or covering or protective covering to the eye, because it covers the scleral area, and the sclera is white. The only time we really see it is if someone's got, maybe they're tired, or they've been in an environment where their eyes are irritated. Then you can see little small blood vessels kind of act up, and that's actually the conjunctiva membrane that can get a little irritated. So that's generally when you see it, but most of the time you don't. The lacrimal gland and the lacrimal duct have to do with tears, okay? The lacrimal gland is located in the upper edge of the outer eye, okay? Well, I guess the upper outer edge of each eye, so it's in the lateral area and the upper part. That's where tear production is originated. Then we have a duct that actually, the gland wraps around and has some ducts that actually lead to the lacrimal duct, which is actually on the inner or nose area of the eye, right in the inner corner or the inner canthus. Okay. So this is our anterior view of our eye. So they're using nasal side. So this would be our right eye, because this is nasal side, and this is the temporal side, or near the ear. Okay. So here we have our upper eyelid. The sac is actually here. The lacrimal gland is under the eyelid here, but the duct actually comes in over here, which is where our tears are generated from, is the nasal side, or the inner canthus right here of the eye. Number 1 is sclera, so that's the white part. The iris is our colored part, and we know that that can vary depending on the individual. The pupil is the dark part in the middle. That's the area that can either get smaller or bigger depending on the response to light. The limbus is this very outer region between the sclera, which actually is the conjunctiva, and the iris. The conjunctiva lines the inner layer of the eyelids as well as the outer surface here. And then this area here between the two lids is called palpebral fissure. You'll see palpebro in certain, or as a combining form that actually refers to the eyelids. Okay, this is the inner canthus, this is the outer canthus, and then our eyelids. Also, our types of hair. There is a sebaceous gland that's associated with each one of these, so sometimes those can get clogged and cause a problem. Okay, but the eyelids are protective to try to prevent foreign bodies from getting into the eye. Let me see what I can do with my. Well, let me find something else to do with my thing. Okay, so then we have eyelids and eyelashes. The eyelids are continuous with the skin, and they actually cover the entire eyeball. This does help to keep the surface lubricated. We've heard of dry eye. That's what can happen if we have issues with lubrication with the eye, but it also protects against debris and dust, and that blinking motion allows a little bit of that fluid to be released so that we keep it moist. Okay. Eyelashes are located along both edges. Usually they're a little longer on the upper than the lower, but they prevent foreign materials from getting in, but they can be a source of infection because of that, because of the sebaceous gland that's associated with each one of those eyelids or hairs that are within the eyelid. Okay. So question, the separation between the upper and lower eyelids is called, and we mentioned here that palpebro refers to the eyelids, so the answer to this one is a palpebral fissure. Okay. Oops. Okay, so then we have the sclera and the cornea. The sclera is the white part of the eye. We kind of already got into this one. It's thinnest over the anterior portion, so that's the front part, and it's the thickest, basically the rest of the area posteriorly. Okay. The cornea is a kind of a transparent, non-vascular layer that covers the colored part of the eye and the front part. So that's why the sclera is very thin, because the cornea actually lies over that area and helps to refract light as it enters. Okay. We talked about the conjunctiva. That's a mucous membrane that covers it. It begins at the edge of the cornea and covers anteriorly and into the eyelid area. Then we have a middle vascular layer of the eye. So we have an anterior layer. This is sort of the middle layer, the choroid. This is just beneath the sclera, and it basically is the extensive capillary and blood supply to the entire eye. So that's a very important layer because it allows the area to maintain nutrients, so that the eye is very vascular and has to have that oxygen supply to function. The area anteriorly at the choroid also involves is the iris and the ciliary body, and these are important. The ciliary body actually suspends the lens and actually helps to bend and refract, or either contract or dilate the lens. Okay, so the choroid, that second layer, also has those two structures within it as well. Okay, the iris is the color part, which is actually a sphincter-like muscle. Okay, and then the pupil is just the opening in the center of the iris, and that actually controls the amount of light. That's actually where light enters. Okay. Now the lens, we kind of touched on this already. The lens is also colorless, but it's biconvex, meaning that it's kind of football shaped, and it aids in helping images focus clearly on the retina. And this is the term that I mentioned earlier called accommodation, where the lens can actually, the muscles can relax and allow it to become flatter and change the angle of the light versus needing to contract it and have things focus clearly on the retina. Okay. And then the ciliary body actually is located on either side of the lens and actually has suspensory ligaments that come down and help in that contraction process. Suspensory ligaments actually are attached to the ciliary body. They hold the lens in place, and then they can either contract or relax, adjusting the shape of the lens to allow the focusing of the eye to come in properly. Now, the retina is the inner layer. And the inner layer is important. It's the innermost layer of the eye, but it's important because it maintains and has all of the nerve cell layer, okay, for the eye. And so there are special cones that are there, special nerve receptor cells that are called rods and cones. And it is the combination of how those are stimulated and what particular color may be triggered that actually allows us to be able to send signals from those specific nerve cells through the nerve to the occipital lobe. The optic nerve is cranial nerve number 2, and it is the nerve that picks up it is attached to the retina and picks up those signals from the rods and the cones and actually sends the image to the occipital lobe to be transmitted as vision. Okay. Rods are responsible for vision, mostly in dim light and peripheral vision. There's a ton of different shades of gray. There's like 100 different shades of gray, and the rods are responsible for that vision, both dim light and peripheral vision. There's a lot more rods in the retina than there are cones. Cones are responsible for visualizing color. They give us our central and focused vision and bright light vision. Okay, there's a lot less of these. When we're dealing with cones, we're basically dealing with 3 different kinds. We have red, green, and blue, and that gives us our light spectrum, and any combination, depending on how much those cones are triggered, gives us all different colors of the light spectrum. Other structures that are important with the retina are the macula lutea. That's sort of a yellowish spot near the center of the retina. And that's actually where the optic nerve and the main retinal artery come out of. The fovea centralis is in the middle of the macula, and it's a little small depressed area. And this is actually the sharpest image that can be obtained with focusing directly. So that fovea centralis is our central vision, which allows us to read and see typed words and what have you. So then we have 2 important structures coming out from the retina. Okay, we have the optic nerve and the retinal artery. So the optic nerve is the nerve tissue that actually picks up the impulses from the cones and the rods, transmits them from the retina to the brain via the optic nerve, which is cranial nerve number 2. Now the optic disc is just an area within the macula. Within the macula lutea that has no rods and no cones. It's considered the blind spot because it doesn't have any of those photoreceptors, but it serves as a point of entry for the artery, which is a retinal artery, as well as the exit of the optic nerve. So that area is called the blind spot and has no photoreception because that's where the artery and the nerve either enter or leave. Okay, so this is a lateral view of the eye. We'll blow it up a little bit. Maybe that's too big, I don't know. Okay, so here's our structures here. So we'll start anteriorly. Okay, so you can see that here's the cornea. That's that very outer layer. Well, actually, let's start with the conjunctiva. Conjunctiva is that membrane that lines the inner eyelid and is the very outer mucous membrane covering of the eye. Right below that we have the cornea. Okay, so the cornea kind of runs synonymously with the sclera. Okay, but the cornea is here because it has to help aid in bending light. It works with other structures within the eye to help adjust that refraction of the light coming through. Okay, so cornea is here. Sclera is number one because it's basically the white part, but once it gets to this point, it turns into the cornea. It gets real thin, and then the cornea is on top. Okay. Then we have a small chamber underneath the sclera and the cornea here called the anterior chamber. This has a very small amount of watery fluid called the aqueous humor. This also works with the cornea as well as the lens as well as the fluid back here to help refract the light that enters the eye so that it can eventually focus clearly on the retina, which is this inner layer right here where all the nerve cells are, the photoreceptor cells. So then we come here, and this is kind of weird looking. It's blue, but that's actually the iris, okay? And once again, it can be different colors. It can be green, hazel, brown. That can be a whole genetics lecture if we talked about that, but that is actually a sphincter-like muscle. Within that iris is the pupil, okay, which is the hole. And the iris can either open up wider to allow more light in, or it can constrict to allow less light in. But here's our path of light going through the pupil, and that hopefully it will focus clearly on the retinal area here. Then as we move back, we have the ciliary body. So this is this little pink area right here on both sides, and then there are suspensory ligaments. You can see little spaghetti-like strands right here, and then our little white oval shaped, looks kind of like an egg right now, is the lens. And once again, these suspensory ligaments can relax or contract and allow this area to stay kind of roundish, or it could flatten it out. Okay, and once again, this works in conjunction with the cornea and the other fluids to help refract and bend light so that it's focused on the eye. Okay, in this area here, you can see it's called number 15 here, the posterior chamber. So we have an anterior chamber here. Then we have a posterior chamber here that actually bathes this area with fluid as well. So this whole area has an aqueous fluid going through it. Anterior chamber, posterior chamber. Okay, so there's watery fluid up here. Then as we work our way back to this globular or globe-like part of the eye, there is a gel-like substance in this area called vitreous humor. So this is more gel-like, but everything up here in this area is watery. Okay. This is actually an area that is affected when we have the eye disease glaucoma. Glaucoma comes from an alteration or an increase in this, or a decrease in getting rid of or absorbing of the fluid in here. An increase in the aqueous humor here can put pressure on the optic nerve back here and actually lead to blindness. That's what glaucoma does. Okay, and there's a couple different kinds of glaucoma, but functionally what we're looking at with glaucoma is an abnormality or a problem draining this fluid. Okay, and so a buildup in this fluid can cause an increased pressure in glaucoma. Okay. So as we work our way back, we have the vitreous humor here. So this is more gel-like. This is constantly reproducing itself, okay, and needs to do that. This gel-like vitreous humor doesn't reproduce. It's supposed to stay there, and it's supposed to stay intact. And so alterations of the vitreous humor can be very detrimental to vision. And so some of the issues that can revolve here are when we have diabetes. Diabetes can start, if you see these blood vessels coming out in this choroid layer here, when we have diabetes, the alterations in sugar level can start to cause hemorrhages and problems with the vessels here. And then it can actually seep and leak into the vitreous humor and lead to forms of blindness. Okay. A retinal tear or retinal detachment from a head trauma can detach this area here, cause fluid or blood leakage into this area, which can also lead to blindness. Okay, so this part of the eye is extremely delicate. And this choroid layer, say the outer layer here, the white layer is the sclera. This layer number 4 here is the kind of middle layer, which is the choroid. That's where all these vessels stem out of. And then in here, that inner layer is where the photoreceptor cells are, the rods and the cones, and that's the retina. Okay. Our fovea centralis is a very small focused area here where we have our extreme I guess, focused or central vision, to where everything else around here would be considered peripheral vision. Okay. Here's our macula lutea in this area, and then that's where it's considered the blind spot. And then we have the optic nerve coming out, and then we also have a retinal artery and retinal vein that go in there. Okay, so this is pretty detailed, but it is important to have a good working knowledge of this anatomy. Okay. Oops, go back up. Okay, so we kind of went through all of those areas. The anterior chamber is in front of the lens. It has aqueous humor. The posterior chamber is behind the lens, but it's also filled with aqueous humor. And so it's important that the flow of that fluid be able to go back and forth. Otherwise, it can lead to a disease process called glaucoma. The posterior cavity itself is posterior to the lens, and that posterior cavity is the larger one, the globular one, the globe-like one that actually has a gel-like substance. Okay, it is not constantly reproduced, and blindness can result if that vitreous humor starts to escape from the eye, or if blood vessels actually leak into the vitreous humor or something disrupts that. Okay. Both of those fluids, okay, humor actually refers to fluid, okay? The aqueous means watery, vitreous means gel-like, but both of them help and aid in refraction of light. Refraction is basically just bending, okay? But you have to bend it accordingly in order for light to actually travel through the pupil and to focus in on the retina. If something disrupts that refraction, then it can lead to blindness or difficulty seeing, okay? True or false? The fovea centralis of the retina provides the sharpest image, also known as peripheral vision. Okay, so yeah, this question's a little bit funky because of the way they word it. So the fovea centralis does help directly focus on for central vision, but it's called central vision, not peripheral. Peripheral is everything, away from the center. Central vision is an intact fovea centralis is important to have accurate and healthy central vision. Okay. All right, so kind of recap a little bit on the process of vision. Light rays enter, they're transmitted through the cornea first. Then we have to go through which aids in bending or refracting the light. Then we have the aqueous humor, that's the fluid in front. Then the light actually goes through the pupil. Then it has to be transmitted through the lens, which can either flatten or contract to help aid in accommodating that light through. Then the vitreous humor also acts, and then the combination of those things then hopefully will give us a focused image on the retina. Okay, as long as the retina is intact, then those photoreceptor cells can transmit an image through cranial nerve number 2, which is the optic nerve, to the brain, and the brain interprets that image as vision. Okay, remember we're dealing with the occipital lobe, which is posteriorly. Okay, so we talked about accommodation as far as focusing with the lens. There's also a word called refraction. So refraction is also the process of bending light rays as they pass through the eye. Okay, but it's important that things refract appropriately in order to focus a clear image on the retina. This is where we get refraction errors when we look at people that are farsighted or nearsighted, or astigmatism. Astigmatism actually refers more to the cornea, but errors of refraction occur with there's going to be different things that cause refractive errors. You can have an eyeball that's abnormally shaped. You can have the lens that doesn't accommodate to seeing near objects, which is kind of what happens with presbyopia, when people, after a while, the lens doesn't contract as much, and so then you can't see near objects, and you got to have your arm 1.5 feet away so that you can actually see. But what can happen is you'll get vision that's blurred. You can see, it's just blurry. And so this is where adjustive or corrective lenses or contacts come in, so that we can actually bend the light rays accordingly so we can see clearly on the retina. Okay, so let's talk about some of the pathologic conditions. Remember, go through this anatomy a little bit, look at all the combining forms and suffixes that go along with those particular eye structures. It's very important, okay? Okay, so let's go through a few disease processes. I may skip through a few of these that are maybe, I'll say, less common. Nothing in here isn't not important, but I'm just going to kind of focus in on the ones that I think are a little bit more readily situations that you would actually come across clinically. Okay. So astigmatism is a refractive error that causes the light rays that enter the eye to be focused sort of irregularly on the retina. Now, this is usually because the cornea is abnormally shaped, okay? And there are LASIK, and radial keratotomy, some of those other eye surgeries that can actually adjust the shape of the cornea and then allow people to actually be able to see without lenses or glasses. Now, people can have astigmatism because astigmatism refers more frequently to the cornea, but then when you have things like farsighted and nearsighted, that can refer to the lens. And so some people can have both. They might be myopic with astigmatism. So it really kind of depends on what's going on. Astigmatism usually is an abnormally shaped cornea, but those new laser procedures can sometimes adjust the shape so that people don't have to wear glasses anymore. Okay. Unless they have another refractive error going on, and maybe they might have to, but sometimes they can cure or help the astigmatism. So blepharitis, blepharo, refers to the eyelid margin. We talked about palpebra being that distance between the two eyelids. Blepharo refers to the actual eyelid itself. So this is where you actually have an inflammation of the eyelid. It seems kind of strange, but this can actually be of bacterial origin, allergy, or even seborrheic, where you have increased in oil from the sebaceous glands, and it can cause sort of a dandruff-like appearance on the eyelid. And so there's a couple of different things you can do to take care of this. We used to prescribe what was called eyelid scrubs with baby shampoo that doesn't irritate the eye. You would just take a Q-tip and kind of rub over it a little bit, and that would help. There's some other things that you can do for it, but it's basically sort of having dandruff of the eyelid. Now, blepharoptosis, if we look at our word here, blepharo refers to the eyelid. Ptosis means drooping. So this is when the eyelid becomes partially droops or entirely covers the eye due to some sort of weakened muscle. Now, there's a number of different causes of this. One of the autoimmune diseases that we have talked about is myasthenia gravis, and so this is one of the first signs of myasthenia gravis is a drooping eyelid, but there can be other things. If someone's had a stroke, this could happen. If someone has had Bell's palsy, this could happen. And there are some other disease processes that can happen in the geriatric population that cause this to happen. So basically, it's just a drooping of the eyelid from a weakened muscle, but the cause can be a multitude of things. Okay. So this just shows a picture of blepharoptosis, what it looks like. Sorry, let me get it in view. So where you can see this one's partially, but the problem is if it's weakened, it can obstruct the visual here because you can see the pupil is partially obstructed. So it's going to give you not really a blindness, but just a difficulty with vision. Plus, if we're not blinking enough, you can also get a dry eye from this. So that's why this condition can be problematic. Okay, now blindness can come from a number of different things. Just going through the anatomy that we have, you can see that there's a number of different things that can actually lead to blindness depending on what you're dealing with, okay, depending on where the abnormality lies, okay? So we're looking just at blindness itself, or what the term means. We're looking at legal blindness is someone whose visual acuity, even with appropriate corrective lenses, is at best 2200. So that's like the big E at the top of the Snellen chart that you look at. And so that is someone that they sometimes can see images and colors, but everything is just completely blurry. Okay, now it could be different. It could be a glaucoma case from poor drainage in the anterior chamber of the aqueous humor, or it could be somebody that's had some sort of diabetic, there could be different causes of blindness. This is just the actual clinical assessment that would actually say if somebody's here, regardless of what the cause is, they are considered blind. Okay. Now, monochromatism. So if we break this word up, mono means one or single. Chromo means color, and this is just another fancy word, or chromato means color, and then ism is pertaining to, okay, an ism. So this is someone that has an inability to perceive generally a visual color. Okay, so when we look at our cones, the cones have 3 different colors, and depending on how much those colors are stimulated will give us the entire light spectrum color scheme. So we have red, and we have blue, and we have green. And so if you're missing one of those, if something happens, okay, where those particular photoreceptors don't develop, some people can have one color, or they can have sometimes 2 colors, okay, that are affected. Males tend to be more affected than females because this is an X-linked inherited trait, which means that it's carried on the X chromosome. And so females have 2 X chromosomes. And so if one has this, the other one, the good one, will take over. Males have an XY. So if they're carrying this on their X chromosome, then they will show this trait. Okay, so monochromatism is the official term for color blindness. If you were to see the word achromatism, with A in front instead of mono, that would basically mean lack of or without. So that would be someone who basically doesn't have any of those cones to see red, green, or blue, and they would mostly see in different shades of gray. Okay. Now, cataract is a specific disease process. It's actually been around for quite a while. And this is where the lens actually becomes opacified. And so the lens that we talked about, which was that oval-shaped egg-looking structure that helps to accommodate, to either contracts or relaxes and helps and aid in accommodation, becomes progressively cloudy and losing what's normally transparent. Okay, and so what happens is it basically acts as a barrier and light can't get through. And it can be a slow progressive process with this happening. It's not something that happens overnight, but it can take a number of years. It is more common over 60, but there are people under that it can happen. Age tends to be the highest risk factor, but so does sunlight. So wear your sunglasses, because sunglass wearing does kind of help to prevent this from happening. A chalazion is a little cyst or nodule that's on the eyelid, resulting from an obstruction of the meibomian gland. So the meibomian gland is a specific sebaceous gland that secretes sebum in the eyelash margin. Okay, and so it's responsible for lubricating the eyelashes. And so if one of those becomes obstructed, then it can lead to a cyst or a nodule, and that would be called a chalazion. Okay. It's a little bit different than a stye, and we'll talk about that in a little bit. We'll get to stye because there's another word for stye. Conjunctivitis is an inflammation of the conjunctiva, and this is usually the only time when you see the conjunctiva, that it's that protective membrane covering over the cornea. But if someone has allergies, or they get an infection in the eye, or maybe they're sensitive to smoke or grass or something like that, that's when you'll start to see like the eyes looking a little bit red. And so that's when you actually kind of notice this. If it's a bacterial infection, it's also called pink eye. Okay, and so if you get somebody presents to the clinic and they're complaining of kind of a sticky or a weird sandpapery situation, and then they wake up the next morning and the eyelids are kind of stuck together and there's a lot of discharge from the eye and it's red, that is usually a bacterial or acute conjunctivitis. That particular situation is a bacterial infection. You can usually treat it with eye ointment or eye drops. However, there can be viral cases that'll come along with a cold or a flu that generally you don't have to give. Their eyes will get kind of diffusely red, but there isn't as much discharge. And so those cases will usually resolve without needing any treatment. But the bacterial version or form is very contagious. For the most part, it's not a horrible infection, but it's very easily passed. And so you can just shake someone's hand and touch your face and you can get it. Touching a doorknob with somebody that touched it can give it to you. So it's very easily passed, and generally in the pediatric population, if a child gets it, the school will send them home and make them go to the doctors and get drops or ointment for at least 24 to 48 hours before they let them back in. Otherwise, half the class will wind up with it. Then there's cases of allergic conjunctivitis, and there are some specific eye drops if people have really severe ocular allergic symptoms, if they're really, really sensitive to certain things and really, really have recurrent cases of eye itching and dryness. There are there are specific eye drops that can be used for that, but allergic is definitely different than bacterial. And generally, you don't call bacterial or allergic or viral is not considered pink eye per se. A corneal abrasion is where you get a little bit of a disruption of the corneal surface. Generally, an eyelash or a small foreign body. You can actually scratch it from a fingernail. Contact lenses, if not placed correctly, can cause a problem with that too. And so the thing is, the corneum can get easily infected, and so that's why abrasions. We'll talk a little bit later. There's something called a fluorescein lamp that you can actually use to detect if someone has a corneal abrasion. They used to give eye drops and put a patch on the eye for a day or two with this. They don't really do that anymore, but generally they will give, they'll at least monitor it and give antibiotic eye ointment or drops just to make sure that that person doesn't get an infection. So the term used, or this term describes drooping of an eyelid, which could be caused by an underlying disease process. Okay, so remember, we talked about the term blepharo refers to eyelid, and so itis is inflammation, and ptosis would be drooping. Okay. Now, diabetic retinopathy, very, very significant situation. It's the more common cause of blindness in the United States, and eventually 1 out of 5 diabetics will get to some point where they've got some sort of retinopathy changes because of poorly controlled diabetes. And so that's what retinopathy is. It's where we have a person that's had diabetes uncontrolled for a prolonged period of time, and what the tissue, the small blood vessels can be affected severely by this. And so when we look at small blood vessels in the heart or in the kidney or in the eye, these are very sensitive areas, and those high sugar levels for a prolonged period of time can disrupt those small vessels, cause them to bleed in the eye, and then they leak into the vitreous humor, and then it can result in blindness. Okay, so diabetic sugar control is an extremely important facet of dealing with diabetes, because the small blood vessels throughout the body can take a toll over time, and this is one of the disease processes that can occur because of uncontrolled diabetes. Okay, so when we're looking at the pathology behind that, we're looking at retinal scarring. Okay, the increase in sugar in the blood vessels causes there to be basically an increase in volume of blood, and then for a prolonged period of time that can actually lead to hemorrhages and microaneurysms. So you actually get those blood vessels, they start to explode and pop, and then they leak into the vitreous humor, and that leakage affects the refractive error, affects the sharpness of vision. And once again, it's not everybody's going to manifest this the same way, but it just depends on your body structure and how you manifest the disease. But this is the pathology behind the retinopathy. Okay, so we have a couple of structural things that can actually occur with the eyelid itself. And so there are situations, it's usually more common in the elderly population, where we actually have changes in the actual structure of the eyelid itself. And so we have something called an ectropion. So ectropion refers to turning out, or an eversion of the eyelash margin from the eyeball. Okay, and it kind of exposes the eyelid and the eyeball and the surface of the surface lining of the eye itself. It is more common in the lower lid, and once again, generally we don't see this in younger population, but in the older population with different disease processes, the muscles get weak, and then what can happen is the eyeball doesn't stay lubricated, then it gets dry, and then the lining gets dry, and that can all lead to problems with vision. Then we have an opposite problem that can happen called entropion. That's actually where the eyelash margin turns inward, and then kind of results as a similar sensation as a foreign body, because then the eyelashes can then scratch the cornea. It can lead to redness, tearing, all of those symptoms. And then it can also cause problems with the cornea or the conjunctiva. And so we have an ectropion, which is a turning out, and an entropion, which is a turning in. Okay. So there are pictures later on of that. So there's two other things that you'll see that you could get confused with. So ectropion is out, entropion is in. Okay. Now exophthalmia here, exo means out. Okay. Here we're referring to the eyes, and this is a condition of. Okay, so this is an actual protrusion of the eyeball itself. Okay, exophthalmia is a condition we normally see kind of isolated to an endocrine condition called hyperthyroidism. And so what happens in that condition is there's an increase in the body's metabolism, and that chronic increase in metabolism actually leads to an expanded volume of the orbital contents, which then actually protrudes the eyes outward. Okay, and so we don't generally see this with other things. There is a tumor in the eye called pseudotumor cerebri that will sometimes cause this condition to occur, but most of the time that is unilateral. Graves' disease or hyperthyroidism generally is the disease process that causes this, and generally if this happens, you've had that disease process for a while, because it takes a little bit of time for that to happen. But it is a pathognomonic sign of Graves' disease if you have that. Now glaucoma, I kind of touched on briefly earlier. Glaucoma is a disruption of the aqueous humor in the anterior and posterior chamber. Okay, so something happens. Either you have an increase in fluid or you have a decrease in movement of the fluid or reabsorption. And so what happens is you get an increase in intraocular pressure, and that intraocular pressure leads to damage of the optic nerve. The unfortunate thing with glaucoma is it's generally silent. And so most people don't have a whole lot of symptoms. So that's why getting an eye exam every year is really important. There's a machine called tonometry or a process called tonometry that does a little bit of kind of delivers a little bit of a puff of air to your eye, and it can actually determine the intraocular pressure. If someone is starting to develop this, then there are eye drops that can be used that are preventative, and so that's why it's a very preventable form of eye disease. It is a little bit more frequently seen with diabetics, so it is a different disease process than diabetic retinopathy, but that alteration in aqueous humor flow does seem to be common with diabetics, although you can get this without having diabetes. So it's really important to make sure you get your annual eye exams, especially if you're over 40. There's a couple different kinds of glaucoma. I don't really get too caught up in this. There's a open angle glaucoma, where you actually get your peripheral vision affected first. And then you have an acute closed angle. So I know there's not going to be any specific questions that differentiate between these two. But this one is a little bit more symptomatic to where the closed angle, the chronic open angle is a little bit more of a slow process that occurs. And so this one tends to be gradual, where people don't notice it, to where the acute one tends to be a little bit more abrupt and a little bit more rapid in occurrence. People will come in complaining of blurry vision, and a prototypical complaint is halos around lights. Okay, they'll have sensitivity to light, redness, and they're seeing halos. And so this particular person can lose their sight quickly if it's not dealt with. Okay, if they can identify it and get procedure started and medical treatment started, we can prevent loss. But this one is a little bit more rapid and has to be dealt with immediately. Heminopsia, so hemi means half. Nopsy refers to vision, and lack of. So this is where we have lack of vision in one side of the visual field. So this is usually a little bit more common with someone that maybe has had a stroke or some sort of brain damage on one side, and then they get an opposite side visual field. There could be a situation where somebody were to have a small blood clot that could do the same thing, but this is where we're actually losing vision in one half of the visual field. Okay. Hordeolum. So hordeolum is the actual term for a stye. Okay, stye is basically a bacterial infection of an eyelash or a follicle in the sebaceous gland. Okay, so this will be your prototypical pimple-looking situation in the eyelid. Sometimes it can be in the actual eyelash itself, or it could be farther up in the lid. And so these sometimes need to have antibiotic drops. Sometimes they even need to have oral antibiotics, depending on the severity. Warm compresses can help to kind of break it up a little bit. But these generally will subside on their own. But if they don't, if warm compresses don't take care of them, then you need to see a specialist and have it dealt with. Okay, so question, true or false? Impaired drainage of vitreous humor is the cause of glaucoma, which must be caught and treated early. Okay, so obviously we've talked about the vitreous humor is not the part of the eye that has movement or reabsorption. Okay, so the vitreous humor does not cause glaucoma, it's the aqueous humor. Okay, vitreous humor is the one right in front of the retina, and yes, it can, if you have a problem with the vitreous humor or you leak into it, it can cause a problem, but that is not the humor that is constantly moving and is not draining and reabsorbing and reproducing. Okay. All right. So we have the aqueous humor for that. So here we get to a couple of refractive errors. So hyperopia is a refractive error that's basically someone who's farsighted. Okay. Their image cannot focus on the eye and tends to give a focal point that's beyond the retina. Okay, and so we need to have glasses that actually, or contact lenses or some sort of corrective lenses that help to bend those light rays so they focus a little bit sooner on the retina as opposed to farther away. Okay, so once again, this is considered farsightedness. Okay, meaning we see far, but we can't focus to see near. And we'll get to the other one. Myopia is a little farther away. I'm going to skip that one. Okay, so keratitis, remember kerata refers to keratin, but it also refers to cornea. Okay, so keratitis would be a corneal inflammation caused by a number of different things. It could be organisms of some sort, trauma, hypersensitivity reaction, tearing. So there's a number of different things that can cause keratitis, but this condition is why it's very important to keep the eye lubricated. Dry eye situations or people that have issues with that can lead to keratitis. And when you get inflammation of the cornea, it can cause numerous problems. It can also be caused from ineffective eye closure. So people that have blepharoptosis or entropion or ectropion can be at risk for this. Okay. Now, macular degeneration. Macula, remember, is the area where the fovea centralis is located. Okay, and so the fovea centralis sits right in the middle of the macula. And if that area starts to degenerate, and the cells in that area in the fovea are destroyed, then we can get something called age-related macular degeneration. It is more common over 65. But what ends up happening with these individuals is they maintain their peripheral vision, but they can't read very well. Anything that's center, so driving, anything that they rely upon to see central vision, which is reading, typing, and being able to read what you type, or even driving and reading signs can be affected. And so they can maintain their peripheral vision, but they start to lose their central vision, and it can be very difficult to deal with. It can be very a profound situation with adults when this starts to happen because it can affect their entire life. Okay. Here's our other flip side refractive error, myopia. Okay, so myopia is the opposite of hyperopia because it's referring to close vision. So this is where people cannot, refractive errors in the lens can't focus on images accurately that are distant. So our focal point winds up being in front of the retina as opposed to behind. Okay. So we can see things close up, but we can't see things that are far away. So this myopia is also referred to as nearsightedness. Nyctalopia, nict refers to night vision. And so these are people that have night blindness. Okay. They can't see appropriately at night or in faint lighting or in dim lighting because of a decrease in a pigment called rhodopsin. Okay, rhodopsin is secreted from the rods, and it allows people to be able to adjust to the low density light and be able to see. These people have an issue with this synthesis of this particular pigment, and so they can see in bright light, but they can't see in dim light or darkness. Now, nystagmus is kind of an interesting condition where we actually have movement of the actual eyeballs themselves, and they're involuntary. People don't do this. And there's different, you can have a vertical nystagmus, a horizontal nystagmus, or something where it's mixed and it kind of rotates. Different lesions on the brain or inner ear can cause this, certain congenital abnormalities, nerve injury, or even alcohol and certain drugs. And when you actually look at the eyes, you have them kind of gaze off. Don't look directly at you, but gaze off to the side, and a lot of times you can see a movement of the eyes, very kind of quick, rapid, involuntary movement back and forth of the eyeballs. Okay. So there's two congenital eye situations that are listed here, and they have ophthalmia neonatorum, and then in a little bit we have trachoma. These are both very similar. Let's see if I can find it. Trachoma. These could be in the same slide, essentially. Trachoma is an eye infection from chlamydia. Okay, chlamydia is normally a sexually transmitted infection, but if a woman has chlamydia and gives birth, then there are case scenarios where that child can either get an eye infection or they can actually get a chlamydial pneumonia. And so if this isn't treated, then it can lead to blindness. And this is the most common cause of blindness worldwide. We don't see it here in the United States because we automatically give every newborn eye drops for both chlamydia and gonorrhea in order to prevent this. Okay, so these are early symptoms that are listed here, but worldwide this is the most common form of blindness because chlamydia is the most common sexually transmitted infection. And when we have underdeveloped nations that aren't getting tested or treated, and these children are not treated with the eye drops, then they can actually become blind from that. If you go back to where we were before, to this one, this also refers to some sort of infection. It can be and I don't know why they separate this, because in reality, there could be other viruses or bacteria. This is basically any kind of eye infection that can lead to conjunctivitis or purulent inflammation of the eye. But prototypically, ophthalmia neonatorum refers to trachoma or some sort of infection in a neonatal's eye, okay, which is one of the reasons why, once again, in the United States, we give both drops for gonorrhea and chlamydia to make sure that no neonate has this. We screen women initially when they come in for chlamydia, regardless of whether they want to be or not. It's part of a routine battery of tests that are done. And if anybody tests positive, then they recheck them at 36 weeks to make sure the infection is gone and that they don't have the infection, because this is a risk. Okay. Presbyopia refers to farsightedness, but it's basically farsightedness of adults, okay, or older adults that are over 40. Those of us that used to be able to see perfectly, and then suddenly everything starts looking blurry. So this is where you can see far away, but that lens just doesn't contract and form the football shape that it used to. It stays kind of flattened, and so it puts the focal point behind the retina, and we need glasses that have some sort of magnifying, some sort of magnification to them, so we can actually bring that focal point up and we can actually see those close objects. So this is someone who can see far objects but not close objects. A pterygium is a little small growth on the inner canthus, on the inner side of the scleral or cornea area. Okay, it's usually a fibrous tissue. It normally isn't an issue, but if it looks like there's a little piece of flesh stuck on the inner surface, that's basically what this is called. And the only time it really becomes a problem is if it starts to intrude on the pupil. Obviously, then it could cause issues with seeing. And so there are some therapies that can be done for it. Prototypically, if it doesn't affect the pupil, they'll leave it alone. But if it does impede the pupil, they'll do some sort of procedure to try to remove some of it so it doesn't affect the vision. Okay. Causes can be chronic dry eye, allergies, and sometimes they think even UV light. So people that don't wear sunglasses could be an increased risk for getting a pterygium. And the P is silent, so it sounds like pterygium. So this kind of shows you, you don't see it very often, but I've seen a few people and they're always like, what is growing on my eye? And it's like, well, it's a pterygium. And so there really isn't anyway, once it's there, there isn't anything you can do for the most part, other than, I mean, if someone's got a dry eye, treating it, but prototypically it would have to go in and do some sort of procedure to remove it. If it starts to impede in here, then they would have to go do something because it could affect vision. Now, we talked about how important the vitreous humor is and how that particular fluid doesn't regenerate itself. And so there's a case scenario where if someone has blunt head trauma, you could actually get a retinal tear or a retinal detachment. So this is either a partial or complete splitting away of the retina from the choroid. Now remember, the choroid has the vascular layer. And so when you interrupt that vascular layer, it can create a medical emergency. They need to be, there are laser treatments that can be done to deal with it, but it is considered a medical emergency. They can lose their vision in that eye from that detachment. Same thing with a tear. Tear is a little bit less emergent. It still needs to be dealt with, but a tear is sort of a minor retinal injury to where detachment is a severe medical emergency. Okay, strabismus. Strabismus is basically like a lazy eye kind of a situation where you have the gaze of one eye is not in the same direction as the gaze of another eye. And so you actually have a weakness in the muscles that actually hold the eyeball. Those are called extraocular muscles. And so we have extraocular muscles all around both eyes. And so if one of those muscles is weak, then you can actually have a weakness in the muscle holding that eye, and it causes the gaze to be different. And so that can cause visual issues as well. So we have something called convergent strabismus and divergent strabismus. Okay, convergent, so con means to or close to, so that would be like a cross eye. So someone that looks like one eye is a little closer, their gaze is towards the inward on one eye, so it's basically an inward gaze. And then a divergent would be one that actually turns outward. They also call that walleye. So don't get these two terms mixed up with entropion and ectropion and entropion. This is esotropia. Okay, so eso means in, exo means out. Okay, so do not get these two mixed up with the other two that we talked about earlier. Okay, so esotropia is cross-eyed or convergent. Exotropia is wall-eyed or outward or divergent. Okay, so these pictures give it a little bit easier of a way of looking at it. So here you can see that this one eye has a gaze straight, but the gaze here, the eye, you can see more of the sclera here than you do here if you're comparing it. So this is a cross-eyed situation. Here it's divergent, so you can see how there's a lot more sclera here, so that focal point is this way to where this one is this way. Okay, so here's our cross eye and our wall eye. I don't really know if we really need to go through this. I'm going to skip over uveitis. Okay. All right, so I'm only going to cover a couple of things in this particular section. The ones that are a little bit more relevant. There's some different things you can read through here. There's stuff is in the book that talks about this. So I'm going to mention fluorescein staining. This is a common procedure that's done in a primary care setting where you actually take a sterile saline or a sterile anesthetic eye drop, place a drop on a piece of paper that has a stain, and then let that eye drop fall into the eye. And what it actually does is it will illuminate any corneal abrasions. And so it's kind of stains into a like a light green or yellow. and there's a fluorescent light that you put over, and so you can actually tell whether or not someone's had a corneal abrasion, and it'll usually be linear, because if it's an abrasion, it's usually in a linear, and then it will form sort of a very bright green linear mark on the cornea. So that way you know whether or not someone's had a corneal abrasion or not. I'm not sure all of these are. This laser in situ is what the LASIK procedure is that we actually do for people that have astigmatism. Radial keratotomy is another one. These are the new procedures that when you have that significant astigmatism or the corneal abnormality that leads to visual issues, if you go through this laser procedure, it can correct certain scenarios. Okay. This is an ophthalmoscopy, which is actually utilizing an ophthalmoscope. That's one of the scopes, or one of the things that you see hanging on the doctor's wall when you go to the doctor's office. Prototypically, they will turn the light off to help dilate the eye a little bit, and then take a peek inside the eye and look at the retina. So there's different internal and external structures that you can look at when you're using an ophthalmoscope. The process of this is also called a fundoscopy. So when we check the retina, it's called a fundoscopic exam. So they do this when you go for your eye exams, and some clinical physicians will do this as well as part of a physical exam. Okay, but it's utilizing an ophthalmoscope to check the inner surface of the eye. A slit lamp is actually is a common procedure. They don't usually do them in the doctor's offices, but they will do them when you go to the optometrist or ophthalmologist. And so it's a way where you can actually, it gives you a slit lamp is sort of a vertical, it's a vertical emission of light where you're actually using a microscope in combination with a high intensity light source that actually allows you to examine the eyelids, the sclera, the conjunctiva, basically all of the anatomic surfaces of the external and interior eye. Okay, and so a lot of you that have had an eye exam have probably had a slit lamp exam done. Tonometry, this is the one that I talked about when we're doing a check for intraocular pressure. So tonometry is the test that's done routinely by ophthalmology and optometry when they're checking for glaucoma. So it's really important to go at least every year to 2 years to have an eye exam done over 40. It's a very simple test. They do a little puff of air, and it causes a certain amount of indentation in the eyeball. If it doesn't indent, that would indicate that there's increased pressure and a problem. Okay, very simple test. But definitely necessitates getting an eye exam every year or two over the age of 40. Okay, I think I might be done. Okay, so we covered the eye. That was about an hour. Sorry, it was a little bit longer than I had intended. The ear is shorter. Ear is still pretty cool because there's different, we'll go structurally into the ear. This is a shorter section, so feel reassured that we're about 2/3 of the way through. We're almost done. Okay, so let's go through the ear. So we're looking at the ear. Obviously, we think of the ear as being our primary source of hearing. Obviously, that's true, and it allows us to hear, but it also is involved with our organ of balance and equilibrium. So we'll talk about the inner ear and how it splits off into hearing and to balance. Okay, and then we have what's called binaural hearing, which allows us to hear from two directions. Okay, so structures, once again, just like in the eye, there's going to be a number of combining forms that refer to the external ear structures and the internal ear structures. So make sure you go through the book and note those. Okay, the external ear makes up basically what you see externally, which is called the auricle. Pinna is actually more of a animal or veterinary term. They usually will call the external ear of a cat or a dog the pinna, to where we call it the auricle, okay, which is basically the ear itself, the external ear. Then we have a canal that goes from the outer ear up to the eardrum. Okay, so that's called the external auditory canal. It's lined with cilia that do kind of help to transmit those sound waves from air, localize it into that area, into the external auditory canal, so that that air can then put pressure on the eardrum, and then we'll talk about what happens there. There's also specific ceruminous glands, which are actually a form of sebaceous glands that secrete cerumen. Cerumen is also earwax. Okay, so we do need to have earwax there. It serves a function. It keeps the skin healthy. The problem is that some people overproduce that earwax, and then it can get impacted and cause a problem and obstruct our hearing. Okay. Then the next structure that we come across is the tympanic membrane. The tympanic membrane is also known as the eardrum. It marks the separation of the external ear into the middle ear, and it takes the sound waves that are in the air and then transmits them to beat on the eardrum, which then goes to the middle ear, and it's actually a transition point from air conduction to something we call bone or vibratory conduction. The middle ear encompasses the tympanic membrane. And then the tympanic membrane is attached to 3 tiny bones called the ossicles. These are also called the auditory ossicles. They are named for their shape. The malleus is the one that is attached to the eardrum. The incus is the next one. It resembles an anvil, and it's the middle bone. And then the last bone is called the stapes, and it looks like a small stirrup. And it attaches to the inner ear on the vestibule part of the inner ear and transmits sound waves that were in the air, beat on the tympanic membrane, and then change that air conduction to something we call bone or vibratory conduction. There's also a special tube within the middle ear called the eustachian tube. The eustachian tube connects the middle ear to basically the nose and throat. You'll see it called the auditory tube. However, that could get a little confusing, so the eustachian tube is generally used more often than the auditory tube. Don't get the eustachian tube mixed up with the external auditory canal, and I'll show you that in the picture in just a minute. Then the oval window is sort of the cutoff point between the middle ear and the inner ear. The base of the stapes fits into that oval window, and then we'll get a different form of movement of these sound waves as we hit that point. So then we hit the inner ear. So there's a couple of different structures in the inner ear that are very important. The stapes attach to something called the vestibule. The vestibule is sort of the starting ground for 2 other structures that are extremely important. It's sort of the landing mark. It does have some fluid within it that helps to aid in our balance, and then it leads into another structure that maintains our balance as well. Okay, so it's the landing point for the stapes, and then off to one side we have something called the cochlea. The cochlea is a snail-shaped bony structure. It contains specific fluid called endolymph and perilymph, and those fluids will move in different ways, and then underneath that fluid or within that fluid are special hair-like cells called the organ of Corti. Now, the organ of Corti is the actual true organ of hearing. It is the movement of that endolymph and perilymph that causes these special hearing cells to stimulate sound that was via air, now via bone conduction. Now the movement of that fluid and those small hairs actually transmits those nerve impulses into a nervous intervention that goes from the auditory nerve to the temporal lobe. Okay, so we have a movement of hearing from air conduction to bone conduction to what's called sensorineural conduction. The semicircular canals are also attached to the vestibule. They have 3 loops that are actually sort of in the shape of our 3-dimensional, a vertical, a horizontal, and a diagonal loop that actually give us our balance. Okay, so if you go on a roller coaster ride and run around in circles, a lot it takes if that fluid gets mixed up, and so after you come off, you feel a little dizzy for a while. It takes a little bit for that fluid to kind of resettle itself. Okay, so here is our structure of the ear. Let me get this a little bit more. So here is our auricle or our pinna. Okay, that's our external ear lobe. That helps to act kind of like our trapping of the of the signals through the air. Here is our external auditory canal. Okay, we do have little cilia in here. We have ceruminous glands in here making wax. So a little bit of wax is important. It traps particles, prevents things from causing the skin to get irritated. So you don't want to overuse your Q-tips. If you strip too much of that wax off, then that can lead to an ear infection. Usually it's better to use drops or something else to help dissolve that wax rather than using a Q-tip. You can use your Q-tip on your external ear here, but you have to be careful using it internally. Plus, if you go too far, you can hit that tympanic membrane right there. So this is our external ear right here, the lobe and this canal. If this area gets infected, and it can, swimmers have a very high propensity for getting this area moist and macerated where lots of water gets in here. There are eardrops that you can use to dissolve that water, but if you don't do that, repeated head submersion can actually cause an infection in the ear canal and lead to what's called otitis externa. Okay. Then as we look structurally here, we come to this area. Here's our tympanic membrane. So this marks the junction. It is part of the middle ear. So the tympanic membrane is here. Then you can see these three ossicles. I know it's kind of hard to see them. Make it one more bigger. So here are the ossicles. The malleus is right here. The incus is in the middle. And you can see the stapes kind of looks like a stirrup. And it attaches here to the vestibule. Okay, so this here is the middle ear. Tympanic membrane, auditory ossicles, attaching to that area. Here's our eustachian tube. Don't get this tube mixed up with this one. Okay, this canal is different than this tube. This tube leads to the nose and throat. If we were over here, we would have the nose and the throat. We have to have a little area here that's open so that this tympanic membrane can move. Okay, if fluid gets backed up in here, it can get infected and lead to an otitis media. Okay, what happens when we go up in elevation? We feel pressure here and we have to try to constantly equalize. And so if we have fluid back here, that can't happen. Okay, so the other thing that can be kind of problematic, so this tube is good because it allows for fluid drainage and allows this area to be open so that the tympanic membrane can move. But then if we have a cold or allergies in the nose, then this tube can become inflamed and allow fluid to get trapped in here too. So it's a good thing, but it can also be a bad thing. Okay, so any infection in this area is considered otitis media, media meaning middle. Okay, then we come to our inner ear structures. So once we hit this vestibule, there is some balance structures within here. There's a ucuole and a saccule in here that help with balance. Our semicircular canals are our three loops here that are basically our three-dimensional directions of vertical, horizontal, and diagonal. And there's fluid, endolymph, and perilymph within here. And so obviously if that fluid gets spun around and mixed up, it can cause dizziness and cause us to feel unbalanced. Then when we come over here, we see this snail-shaped structure called the cochlea. Okay, and so within this area, there is endolymph and perilymph as well, with those tiny specific specialized hair cells called the organ of Corti. It is the movement of that fluid in those hair cells that then sends a signal through this little structure here, which is the vestibulocochlear nerve or cranial nerve 8 or the auditory nerve. So this will go to the temporal lobe and then it will manifest in what we know as hearing. Okay, so once again, you can see we have a number of different areas where if something goes wrong, it can affect our ability to be able to hear correctly. Okay. All right, so question. The true organ of hearing is called the organ of Corti. Okay. All right, so it is within the cochlea. The cochlea is the house. The organ of Corti is the actual true organ of hearing. Okay. So that's our anatomical structures. Let's go to a few of the pathologic conditions. We talked about a couple of them already. The cholesteatoma is kind of an interesting thing. It's very rare. We don't see it very often, but it's actually a slow-growing cystic mass that's made up of different chunks of epithelial cells and debris that they can actually find in the middle ear. It's usually a congenital defect where someone is born with this, but chronic recurrent otitis media that's not treated could lead to this. These generally have to be surgically removed because it will impair the ability of that particular ear to hear. Now, as we saw, there was a definition of blindness. Deafness, once again, can be divided into a couple of different kinds of deafness because it really depends on where the deficit is. A conductive deficit or conductive deafness usually is some sort of breakdown in the middle ear, or external ear, which would include the tympanic membrane or the ossicles. So if you have something in that area, if someone has had repeated perforations of the tympanic membrane or repeated ear infections that cause scarring or sclerosis of the ossicles, then that can prevent the transmission of sound waves transmitting to vibration, which then prevents the conduction to the sensorineural or to the inner ear. Okay. Then we have something called sensorineural deafness or hearing loss. Okay, this is generally a problem either with the cochlea, something has happened with the hair cells or the endolymph, or we have damage to the auditory nerve. So once again, this is sensorineural. The middle ear might be okay. The transmission from air conduction to vibratory conduction may be normal, things are getting through, but there's something in the inner ear that is preventing that person from transmitting that correct transmission to the temporal lobe, so we're not hearing correctly. Now, impacted cerumen is a really common problem in primary care. This is one of the first things that medical assistants have to learn how to do is an ear lavage. That those cerumen or that cerumen, the ceruminous glands prototypically a lot of people find that they overproduce cerumen. So we need a little bit of wax, but not too much. So if we get an overproduction of it, or if people get a little too crazy and use Q-tips too much, sometimes Q-tip users that make too much will push that wax and create a wall inside the ear. And so you can oftentimes see Q-tip users because they'll have this very smooth concave wall that you can tell fits perfectly with the head of a Q-tip. So you have to be careful using that. There are eardrops, D-Brox or Ceruminex or some other types of eardrops that you can use that actually break up the wax a little bit and do occasional periodic ear lavages to get that wax out rather than relying on Q-tip use. Now, labyrinthitis is an inflammation of the labyrinth. Now, the picture didn't show it, but the semicircular canals are also considered the bony labyrinth. And so if that area becomes inflamed from a virus or from a disruption of the fluid within there, you can actually get dizziness episodes called labyrinthitis. Severe episodes where you have excessive spinning sensation are called vertigo, and we'll actually see vertigo in just a little bit. Mastoiditis, the mastoid process is we didn't talk about this in the anatomical features, but if you look at the anatomy, the mastoid process is a process that's actually behind the opening of the ear. And if someone has repeated middle ear infections and doesn't get them treated, that infection can start to spread. And if it gets to the mastoid process, then it's not that far away from other brain structures, and it can cause a significant issue. So mastoiditis is usually repeated infections or inflammation in that mastoid process, which means that that chronic recurrent otitis media has started to spread. Okay, that's not a good thing. Meniere's disease is a really unfortunate combination. And when people have Meniere's disease, they have there's 3 or 4 different symptoms that can be associated, but each person can have a different amount or different degree of severity with this. I'm gonna make this smaller, I think. So it's a inflammation or infection of the inner ear. And generally we have an accumulation of fluid either in the labyrinth or even in the cochlea. And so what will happen is because we're dealing with an overproduction of fluid in this area in the labyrinth and or the cochlea, we will get episodes of vertigo, which is intense spinning, hearing loss, they can't hear, They'll have a feeling of pressure or fullness, and then they can also have tinnitus, which is ear ringing. So it's a combination of spinning, ringing, I can't hear, and it feels full. And it can, once again, not everybody's going to have all of those. They'll be in different degrees, and sometimes the ear ringing will come and go, but it can be a very significant issue to deal with. True or false? A cholecystoma can be treated with oil or hydrogen peroxide to soften the wax, then irrigate until removed. Okay, so remember, cholecystoma was a cystic mass, so doing those measures isn't going to take care of it. Those are measures that we would do for having a wax impaction or cerumen impaction. Okay. Now we'll talk about ear infections. These are really common. So I already mentioned, we talked about, this doesn't want to come into view. Oops, let me go backwards. So sorry. So we have external otitis or otitis externa, which is swimmer's ear. I kind of mentioned this when we went through the anatomy, where we get an inflammation of the outer or external ear canal. Generally, bacteria have invaded, or sometimes with people that have immune compromise, they can get a fungal infection in there as well. It can hurt. Just like an inner ear infection. If the ear is tugged on, or that the hard piece of cartilage called the tragus is pushed on, it will hurt. The canal can be swollen with pus and pretty intense pain. It can obviously affect hearing as well, because if that area is completely closed with infection, then you can't get your air conduction through, so people will also complain of a decrease in hearing with this. It is more common in swimmers because of constant moisture and in the ear canal and causing it to become macerated. There are boric acid ear drops that are called swimmer's ear that can be utilized after people swim, that dries up the excess water, that helps prevent this from happening. Otitis externa is the external ear canal. Then we have otitis media. So media means middle. So this is where we basically have an infection in the middle ear. Fluid or bacteria get up behind the eardrum and cause that eardrum to become red and swollen. It's more common in infants and toddlers because the eustachian tube is straighter in kids, but it does become a little curved or S-shaped as we become adults. So we don't see as many ear infections in adults. It can still happen. I'm not saying it doesn't, but it is more common in infants and toddlers because their eustachian tube is very small and straight. And so it's very easy for bacteria from the mouth or nose to climb up that eustachian tube and cause an infection. Repeated cases can cause issues with the ossicles, and we'll see a condition of that in just a little bit. Then we have something called serous otitis media, which is acronym SOM, as opposed to AOM, which is acute otitis media. This is where fluid gets tucked behind the eardrum. It isn't necessarily infected, it's just serous. And so this can happen with people that have allergies. We'll see serous otitis media where people will come in and you'll see what's called an air fluid level when you look behind the eardrum. These people will complain of difficulty equalizing. It can cause pressure, and it can hurt, and it can decrease hearing. A lot of times you have to deal with the inflammation in the eustachian tube. You have to give allergy nasal sprays, things to prevent the allergies so that that eustachian tube stays clear and open so that it doesn't cause that area to get infected or bottled up with fluid. Then we have something called suppurative otitis media. Suppurative is just another word for pus. We talked about purulent being pus. Suppurative kind of indicates pus as well. And so this is where you actually get a collection of pus in the middle ear. It can cause all the same symptoms that an otitis media, but essentially it's a synonym of acute otitis media. Usually you won't see suppurative, but if somebody notes that they see a greenish color, usually it's red and inflamed. So most of the time this will be called acute otitis media, not suppurative. Now, otosclerosis refers to sclero. Remember, means hardening. Okay, so this is a condition of the ear hardening. But in this particular case of the oto, we're actually dealing with the stapes. And this is where the third bone in line that actually attaches to the vestibule becomes hard and sclerosed. And so it doesn't move well. And so what happens is you can get a form of hearing loss. So this is a conductive hearing loss where that vibratory sensation is impaired because of sclerosis of the stapes. Now this happens a little bit more commonly with repeated cases of otitis media. They actually do have a case where you can do a staphoidectomy, where you can actually go in and do microsurgery and replace that stapes in order to restore the vibratory sense that goes through there. Okay. Now, perf, this is called a tympanic membrane perf or an eardrum perf. Perforation can happen anytime there's pressure increased behind the eardrum. It could be from infection, it could be from fluid, or it could be from trauma. If you have direct head trauma, it can also cause it to rupture. Prototypically, you'll see some sort of drainage. If it's an infection, it usually will have some sort of pus or otorrhea will occur. You'll get drainage of that pus. A lot of times there'll be blood as well mixed in because there is a vasculature to this area. So a lot of times they'll present with an otorrhea with some sort of discharge, including blood. Okay. So true or false? Otosclerosis means the stapes that adhere to the oval window, which leads to hearing loss. So yes, prototypically that's what it means. Okay. It basically means that the stapes is immobile, it is sclerotic, and it does not vibrate the way it's supposed to, so the sound waves cannot be transmitted properly to the cochlea. Same thing here. There's a couple of things through here. Let me see what we got. I'm only going to go through a couple of these. So audiometry, this is important. This is an important definition. It's the process of measuring how well an individual hears various different frequencies of sound waves. This is your prototypical hearing test when you would go to school. They routinely test 4 and 5-year-olds. If you go in complaining of decreased hearing, they'll throw the earphones on you and then give you different pitches at different decibels, different hertz and different decibels to try to see where your range is or isn't. Okay, so this is the process of measuring how well an individual can hear certain tones or the lowest tone that they can actually decipher. Okay. An otoscopy is very similar to when we do an ophthalmoscope view. This is where we use an otoscope. It's the other scope that's attached to the wall when you go to the doctor's office, and it's used to look at the outer ear, as well as the tympanic membrane and the external auditory canal upon exam. So it's basically examining those outer and middle structures. There's different types of hearing tests that you can use. There's something called a tuning fork. And if those of you that have music background might know that you can actually use different tuning forks for different pitches. And so there's a test that you can actually do with a tuning fork. There's one called the Retina test and one called the Weber test. And basically, when we talked about the difference between air conduction, bone conduction, and sensorial conduction, this one test here, we can actually use a tuning fork to compare the difference between air conduction and bone conduction. And then we have another one where we can actually tell the difference between conductive loss and hearing loss. So the book goes into a little bit more depth with these, but both of these are used probably more prototypically by ear, nose, and throat doctors or ear specialists. But we were taught these to use as well to try to decipher if somebody's got a decrease in hearing. It can sometimes give you an idea, depending on whether they pass or fail this test, what kind of loss we're dealing with. So otoplasty, okay, oto means ear, plasty means surgical repair of. So this is someone who actually has an ear job, so to speak, where they actually, their ears maybe flare out a little bit and it's not as aesthetically pleasing as they'd like. So they actually will pull the cartilage of the ear back, and so that the ears are closer to the head. So that's sort of the counterpart to a rhinoplasty, which is having the nose fixed. This is having the ears fixed. And then we talked about the staphoidectomy already when you have otosclerosis, and that stapes is hard and sclerotic from increased infections or what have you. Then you can actually do a graft, and there's a small prosthesis that can be put in that will allow that vibratory pathway to be reestablished. Now, hearing aids, as you can see, we've gone through the different kinds of hearing loss a little bit. So hearing aids don't help everyone. It depends on what their loss is. There are some people that just need to have things amplified a little bit, and so these hearing devices work for that. But if someone has a hearing loss that's more related to the staphoidectomy or the otosclerosis or something going on in the cochlea, there are other things like cochlear implants that can be used. So hearing aids help to amplify things, and there are a number of different styles of them. They talk about them in the book, but they don't cure all forms of hearing loss. A myringotomy and a myringoplasty. Now, myringo is another word for tympano. So myringo refers to the eardrum. So those two are synonymous, okay? This is a surgical procedure where you put a small tube into the eardrum so that it prevents the need to treat ear infections with antibiotics all the time. If that infection starts, it sort of gives it an outlet so that it doesn't build up behind the eardrum and cause scarring of the stapes and of the ossicles. So this is your prototypical ear tubes that most kids will get, usually under a year. Sometimes they need to put them in over a year, but these tubes help to prevent having to treat kids with chronic otitis media when they're small. They can cause scarring of the eardrum, but they prototypically fall out themselves, and then they'll follow up with an ear, nose, and throat and audiometry and make sure that their hearing isn't infected afterwards. A myringoplasty or a tympanoplasty would be actually a surgical repair. So if something that ruptures and causes a hearing loss, you can actually have replacement of that eardrum. And they can also replace the ossicles if need be. So the myringotomy is the tubes. A myringoplasty is where you're actually surgically repairing the whole area. Okay, and another term for tympano is, all right, we just mentioned it, myringo. Okay, those are interchangeably and can both describe basically infections in the ear or procedures that are done. A tympanoplasty and a myringoplasty are the same thing. Okay. Okay, so we finished in an hour and a half. Hopefully that will help you a little bit going through. So I will sign off and I will see you in